Hello, and welcome to the Hazelden Betty Ford Foundation's Let's Talk series of podcasts. My name is William Moyers, and I've been with the organization since 1996. However, before that, in 1989, I was a patient at Hazelden, and so that makes me not only an alum, but a man in long-term recovery from addiction to alcohol and other drugs. Thanks for joining us and for listening in on our series of conversations with my colleagues about the important issues related to research, prevention, treatment, and recovery support. Today, we're talking about opioids, and my special guest is the Chief Medical Officer of the Hazelden Betty Ford Foundation, Dr. Marvin Seppala. Dr. Seppala joined Hazelden in 2002 as our Chief Medical Officer. He's a Mayo-trained doctor of psychiatry, but long before that, Marv, you had a personal connection to the organization, and so before we get to our topic of opioids today, I would just ask if you'd share a little bit about that.
I'm glad to. My involvement at Hazelden began at 17 as a high school dropout. And I'd never even heard of Hazelden, and in fact wondered what it was as we drove in and I saw that name. I had no idea where my parents were bringing me or why. I knew there was something wrong. I had no clue it was addiction, and I learned that in treatment, obviously, and completed treatment at Hazelden and went back to Stewartville, Minnesota, and my family, where I immediately relapsed because I didn't do any of the things that they suggested. But ultimately, about a year and a half later, I finally did, and attending 12-step programs, got sober, and now am also in long-term recovery.
How many years now?
42 years.
Wow. Did you ever, they always talk about living it a day at a time. Did you ever think those days would add up to these decades?
No, not once. My first sponsor was sober 5 years when he became my sponsor, and I thought that was in a lifetime. That was an eternity. How would I ever accomplish that?
And surely you didn't ever have any notion that you would one day become a Mayo-trained doctor and a doctor of psychiatry as the chief medical officer of the organization that you got in treatment from.
Not at all. In fact, part of dropping out of high school was I didn't think I was going to live that long, and so why have a high school degree? And so I had no vocational plans of any kind when I first got sober. I really had no idea, no thoughts, no plans, nothing. Didn't have a clue.
Well, you and I are shining examples that from adversity comes opportunity, and
that's for sure.
The opportunities that we got when we started that journey at Hazelden have resulted in us being here, and colleagues and friends and fellow travelers. So we're here, though, today to talk about a very serious subject, opioids, and certainly the opioid epidemic. It is an epidemic that does not discriminate. It doesn't matter whether you are in the inner city of Minneapolis or in the bucolic suburbs of Wisconsin or Iowa or Kansas. Opioids are everybody's problem, and we at the Hazelden Betty Ford Foundation certainly have seen this epidemic up close and personal. Dr. Seppala, tell us a little bit why opioids are an epidemic.
They're extremely powerful medications. They're necessary for pain relief of a moderate to severe nature, especially like for a broken bone, for post-surgical pain, that sort of thing, really severe pain, so we need opioids for. And before the mid-90s, there was great care in the prescribing of these medications by physicians and other healthcare practitioners, and there was real concern about extended use of them and high dose use of these medications. So there wasn't much of a problem for decades, actually. And then in the mid-90s, a change occurred in which a particular medicine was developed by the pharmaceutical industry and marketed not just to pain experts, which was going on up until this point in the mid-90s, but now they changed their marketing strategies to address primary care. And the suggestion was that they could treat people with chronic pain safely and wouldn't even have to worry about addiction, because this new medicine, OxyContin, was different and wouldn't cause addiction in this population. And they used some really bad science to to publish a couple of things that were used to convince physicians and others of these false truths,
The bad science being that it wasn't addicting.
Yeah, exactly, and that it wouldn't be problems for people. And so suddenly guidelines in regard to the use of these medications started to change, and the prescribing went up dramatically. And whenever any population's been exposed to opioids, of course, a certain percentage become addicted to it. So as the prescribing increased and the number of prescriptions increased in the country, so did the treatment admissions for opioid use disorders or addiction to these prescription painkillers, and coincidentally, the death rate from opioid overdose, which in most of our kind of historical look at addiction, when you think about the cocaine crisis, there certainly was a death rate associated with that, but nothing like what we're seeing now. Or methamphetamine, there's a death rate associated with, high dose methamphetamine use.
Or alcohol too.
Yeah,
right?
Alcohol actually kills way more than any other illicit substance, maybe even 4 times more than everything else combined. But it's primarily people at the end stage of their addiction to alcohol. There's certainly some young people that overdosed on alcohol, but the major issue is end stage. And with the opioids, it's sudden overdose. And in general, it's a young population doing that, and an older population, like in our age group, about 50 or so and above. And it's usually from combining pain medication that they're being prescribed with other medicines or with high-dose alcohol that also reduce respiratory rate, or reduce the rate in which people take their breaths. And that's how opioids kill, is that they alter the brainstem area where respiration is controlled. And opioids slow it down, and if you take enough in overdose, it actually stops us from breathing. And so if you take enough to slow it down some, but you also drank a lot of alcohol that also slows it down, or used something like Xanax, a benzodiazepine, a sedative hypnotic for anxiety or sleep, you suddenly could overdose just from that combination.
So when we say epidemic, and we really mean epidemic, we're not using that as a euphemism or to suggest something. What does it mean that we're actually in an opioid epidemic in the United States?
So the epidemic officially is defined by the Center for Disease Control in Atlanta, and they usually use it in regard to infectious disease. And there's enough people that end up with the disease, enough people die, then they call it an epidemic. And they decided for the first time, actually, in regard to addiction, to describe this as an epidemic based on the high rate of overdose deaths that's been occurring here in the United States. And it was a great stance for them to take, to just, kind of throw down the gauntlet and say, this is truly a crisis. It's an epidemic, and it got everyone's attention.
And I think one of the statistics that you've cited, I think coming from the CDC, is that opioids are killing more people every year than in car crashes, for example, right? Or overdoses are killing more people. And the preponderance of those overdoses are opioid.
Absolutely, yeah. And now there's more people dying from opioid overdoses than died from AIDS at the peak of the HIV, or the AIDS crisis. It's called AIDS crisis then, now we call it HIV, but at its peak, not as many people were dying as are dying currently of these opioid overdoses. And if you remember the incredible attention that disease received, a stigmatized disease, received at that time, and it resulted in tremendous change. And I think of the response, both civically and politically, to this opioid crisis. We're finally getting attention, but there's still controversy. Another stigmatized disease, and if you use just response to crisis as a way of examining the two, I would say this is more stigmatized, because there's less action going on to really address this issue.
And some of that has to do with the fact that addiction as an illness in general is misunderstood. So whether it's addicted to opioids or addicted to methamphetamine or addicted to cocaine or addicted to alcohol, people still look at it moralistically or
Yep.
think that it's a lack of, you're addicted because it's a lack of faith or a bad upbringing. That's not true. We know addiction doesn't discriminate. It's an equal opportunity illness.
It sure is. It's a brain disease. It's a chronic brain disease. It doesn't discriminate at all. We know that the primary risk factor is genetic. So it runs in families. And we also know the parts of the brain involved. It's been well defined in the neuroscientific research.
And yet, opioids are unlike any other drug when it comes to the effects, as you talked about the overdoses, the fact that so many young people are dying. And we saw that. You actually saw that probably sooner than perhaps anybody else in our organization, maybe the mainline counselors. But even nationally, you were one of the first doctors to recognize that this group of patients that were coming to us had a certain set of dynamics that were unlike the addiction we were used to treating. Can you talk a little bit about that? When that was and what happened?
It'd be late
10 years ago.
So 10 years ago, we started to see this increase in treatment admissions for people with opioid use disorders and in our residential settings. And our residential settings usually have groups of men or women of about 22, 24 that gather together with a positive peer culture to support each other and get into recovery. And they do group therapy together and they become friends, and there's a tremendous fellowship that occurs. And when there was 1, 2, 3 people with an opioid use disorder, they'd fit right in and be in that positive, sort of situation. And things would go well. And they had just as, we do outcome studies, they had just as good of outcomes as our alcoholics or anybody else under that circumstance. But then when we started to have more and more people with opioid use disorders on those same units, so let's say there's 6, 8, 10, they tended to bond together negatively. And
why?
And I think it was because they saw themselves as different than the other people with other addictions, and they saw a camaraderie with their peers with opioid use disorders. They'd had a similar experience. I don't think we were adequately addressing them, so I think that's a big part of the why. But also, they have a long sort of detox period. It's kind of difficult. They have a lot of craving, whether on medications or not, for opioid use disorders. And they just started trying to figure out how to bring opioids onto campus, how to get out of treatment early, and they were leaving early. 25% of our people with opioid use disorders were leaving treatment early. We're not completing treatment.
Because of the craving?
Yeah,
dynamic?
mostly, and going back to use, just a horrible statistic. And with that, we also had, within those groups, we call it a treatment milieu, what's going on among all those people. And there were statements like, snitches get stitches. So the opioid use disorder, a younger group in general, upset with like an older alcoholic who told a counselor that this guy wasn't doing so well. And he said that, and other things like that were occurring. And with that, we also saw the national data about the death rate, and we started to see some deaths of our own patients after treatment upon relapse to opioids. So
they were coming to treatment, they were successfully completing treatment as we would have defined it, and they were being discharged.
Yes.
And then they were
relapsing and dying. Yeah, and abstinence itself increases the risk of death upon relapse because they lose their tolerance while they're abstinent. So during the course of opioid use, they develop tolerance really rapidly, and it grows and grows and grows. They need more and more
of the substance.
Yeah, whether it's heroin or oxycodone or whatever, to get the same high. And they're always seeking more because they want that good feeling.
Sure.
They don't just want relief from withdrawal, they want to feel good. And so when they stop using in treatment, that tolerance drops and drops and drops. And they don't really recognize that. And if they leave earlier, they leave successfully, and they relapse, they're not thinking to themselves, I better be careful. with how much I use.
They just want to get high.
Yeah, they just want to get high. And at that point, if they use a similar amount to what they were before treatment, it could be enough to kill them, because the tolerance to the intoxication goes way down, but the tolerance to the respiratory effects of the drug don't change in the same manner, and they really put themselves at risk.
So you recognize this. You start to talk about it within our organization at Hazelden. At the time, we were Hazelden. We merged with the Betty Ford Center. Now we're the Hazelden Betty Ford Foundation. But you see this, and you implement a series of changes in how we approach or treat the opiate addicts. Describe that Core 12 program for us.
So we called it Core 12 for comprehensive opioid response with the 12 steps. And the with the 12 steps part was that we know the 12 steps are really beneficial. We want to keep that solid. We know that a lot of the other types of psychotherapy we use are really beneficial. We wanted that to stay in place. But we also wanted to add some new things. In one thing we added was a group just for people with opioid use disorders, because we kept everyone independent of the kind of addiction they had lumped together.
Sure. We've always done that.
Yeah, and it's always worked.
It worked, yeah.
But because of the issues on those units, we decided we need a separate group to give them the support they need with each other. And that has worked out tremendously. Now they bond in that group in that same sort of positive, pure manner and really support each other. It's tremendous to watch. It happens within a week or two, and it goes on for months and years. But we also added medications, which was a really controversial decision for our organization.
Because why?
Well, of the two medications, one extended release naltrexone, very safe, doesn't cause any kind of intoxication, hardly even know it's in your system. That one was at least somewhat acceptable, but it's a medicine for the treatment of addiction, and some people find that troubling. The other one was buprenorphine, and buprenorphine is a partial opioid agonist, which means it partially stimulates opioid receptors, and for someone naive to opioids, it acts just like the other opioid medicines. So you get pain relief, you could get intoxicated from it, just like oxycodone or hydrocodone or heroin, but it's long-lasting, and when we give that medicine to people with an opioid use disorder, they quickly develop tolerance to it, and what it does is relieves their craving, helps them engage in treatment, and helps them, get on with their lives instead of undermining their lives in the way that regular opioid use would do.
And we've had success with that. In fact, I believe the research that you and Dr. Audrey Klein and others in our organization have been focused on is showing that the use of Core 12 is a successful program.
It's very successful. In fact, I mentioned earlier we had 25% of people with opioid use disorders leaving treatment early. With Core 12, that dropped to about 6%. So over 90% of our people with opioid use disorders complete treatment, which is tremendous. And what we want now is people to stay engaged in outpatient care following residential treatment, or just start an outpatient.
Sure.
But we want long-term involvement, especially for opioid use disorders, because the craving lasts a long time. They need support for a long time. And we had over about 73%, almost 75% of that group transfer to one of our outpatient programs after residential, which is also really tremendous. And we recently got our 6-month data, and it shows really high recovery rates, total abstinence for this population. And it shows we have 3 different groups. We have the group on the extended release naltrexone, a group on buprenorphine, and a group with no medication. And they all had very similar abstinence rates at 6 months. So everything we're doing adds up to success for our patients in that program.
And yet it hasn't been without controversy. I know you were quoted in national media outlets weighing in and articulating our position on this, because there are some who would argue that the use of medications such as naltrexone or Suboxone is counter to an abstinence-based program, and yet it isn't.
No, in fact, you're right that people made statements like we were ruining AA in the Twin Cities because we were sending people there that were on buprenorphine, and this medication, and other treatment program providers and specialists in the addiction field who were solidly in a 12-step abstinence camp were saying that we were ruining the field, we were turning our back on our whole heritage as a 12-step organization, as an abstinence organization. And it was often focused at me because of my role in starting this, and that was difficult, but it was necessary to go through.
Sure.
And it put us in a position to just say, you know, we're responding to a crisis. We're responding to this terrible death rate. We just want to do whatever we can to help these people, to keep them in treatment long enough and keep them engaged in recovery long enough that they start to get into good recovery as individuals. And then whatever they do with the medicine is fine with me. But until then, anything we can do to help was necessary because of the nature of this crisis.
And in fact, our program is designed to taper people off of the medication eventually, and just to give them that full experience in a 12-step abstinence-based environment.
It is. And we don't expect everybody to get off the medication, but we do describe that after they're in good recovery, if they choose to get off, we're glad to work with them and help them to do that and stop the medicine. The extended release naltrexone, really easy to get off of. There's no withdrawal. It's an injection once a month. You just don't get the next one. You don't even notice. But the buprenorphine has a typical sort of classic opioid withdrawal associated with it. If you do it really slow and easy, it goes smoothly, but the last little bit that you have to stop can be really tough on people, and it's such a reminder of their addiction when they withdrew from whatever, oxycodone, from heroin, and it's frightening to people, and it really is a risk for relapse at that point in time, because it triggers subconsciously what addiction was really like, and so we have to really support them through that if they choose to. There's certainly some people that should stay on it long term, and our research study shows that there's people that don't even need the medicine in the first place, but we just don't know who they are yet. So we have to take a stance that since we can't predict who's going to stay sober without medicine, then our expectation is everybody gets recommended to go on a medicine when they come into our program, one of the two. And if they choose not to, we're still going to do everything we can to help them. Because in the end, it's their decision whether to take the medicine or not.
Well, the whole experience we've had shows that there are many pathways to recovery, even along the 12-step pathway. Some people are going to approach it using medication. Some are going to approach it with different perspectives on faith or on all those other components to it. There's not a one-size-shoe-fits-all when it comes to addiction treatment or recovery.
Not at all. And it's so important to recognize that and support people in whatever they really choose in that regard, as long as it makes sense and it's successful. You know?
And it treats them with dignity and respect.
Absolutely.
Now, early in our conversation today, and by the way, we're talking with Dr. Marvin Seppala, the Chief Medical Officer of the Hazelden Betty Ford Foundation. You talked about how this epidemic was born and became the crisis that it is. And what I heard you talking about was the fact that doctors had a role in that epidemic. But wait a minute, Dr. Seppala, doctors are smart. Doctors get a lot of training. What is it that they were missing in their medical training that helped to foster this epidemic?
On average, during medical school, as physicians, we get a single day on addiction.
One day
of
training.
So that'd be 8 hours at most. It's terrible. So when the Affordable Care Act was passed, there was a description that they chose to prioritize addiction as one of the primary illnesses to be addressed, and they forced that issue for the first time politically, which was just remarkable and wonderful. But they did so because they described that 25% of the healthcare budget was in some way associated with addiction. So 25% of the healthcare budget is associated with this one disease. And in medical school, you get on average 1 day of training. So physicians don't know much about it at all. And in general, as a physician, I want to know what I'm doing, and I want to know what I'm talking about. And if you've come to me for help, I want to be able to help you. And if I don't know a disease, I'm going to steer clear of it.
Sure.
Because I'll look like an idiot, right?
Uh-huh.
I'm not going to look competent by addressing it. And that's been a real issue. There's lack of training.
That's one reason why at the Hazelden Betty Ford Foundation, we're known for being an addiction treatment provider, but we have a lot of other components to our mission, and one of them is our medical education for docs. Could you talk a little bit about that?
Yes, we have a program, Summer Institute for medical students, that started at Betty Ford Center, now is involved there and at our Center City campus in Minnesota, where we train medical students for a full week. They get a immersion experience into addiction treatment, and they get lectures about addiction and its treatment. And it changes their minds dramatically at a point in their careers where they're open-minded. Later on that doesn't happen as well. But we also have opportunities for physicians to come in and do the same thing. It's not as frequent, but it is extremely helpful for those docs who really want a quick sort of look at addiction and how it's treated.
Do you have any hope that this country will be able to get on top of the opioid epidemic, number one? And then number two, Dr. Seppala, do you have any hope that we as a country can get on top of addiction as the chronic illness it is?
Yeah, I really have hope we can get on top of this opioid crisis. The prescribing of opioids has decreased about 20% from efforts within medicine to try and address the overprescribing. There's certainly a long way to go. 20% is not enough by any means, but it's a start. And President Trump's budget has $3.3 billion devoted to the opioid crisis, which is remarkable. It's more than ever has been devoted to addiction, which we hopefully it stays there and it gets funded. And I also think this crisis has gotten national attention in a way that no other addiction problem has. And it's resulted in people not just supporting addressing opioid addiction, but also addressing addiction as a whole and starting to examine that differently. Yes. So that makes me optimistic about addiction as a whole as well, and how we'll be able to see it for the disease it is and treat it in that manner going into the future and be much more successful.
Another part to it that's been very encouraging is how we've been able to take what you developed in Core 12 and apply it or take it to other cities and other hospitals and other doctor groups through training.
We have. It's been really exciting to see what we developed in Center City, Minnesota. Go out to major hospital systems and other treatment providers. And
we have a curriculum.
We do, yeah. And describing how to put Core 12 into play in your own treatment program. And the advantage of it is that it uses existing practices, evidence-based practices that, 12-step facilitation therapy, cognitive behavioral therapies, uses group therapies, things that most treatment programs already have. And it just adds a few other components that they can just kind of add on, and they're doing it. And we've found, we've gotten reports that's really been successful for them. And one of the successes is that people are attracted to it. I mean, the staff is, because it makes sense to them. Sure. It's using things they already know. It's adding some other things that make sense. It's evidence-based in that regard. We're just, if you had a cancer that was rare, often they would say, well, we're not so sure that this medicine is going to work for your cancer. So we're going to add this medicine too. And in an experimental way, to give you everything we possibly can. We're just going to add a few things that work for other cancers together in hopes that something kills these cells. And in a way, that's what we did with Core 12. We just said, okay, this works, this works, this works. Let's just put it all together and see what happens. See if we get better outcomes from that combination than trying to do things independent of one another.
So you're hopeful overall?
I am really hopeful, yeah. I know opioid addiction is long-standing. So, we've had cocaine crisis, methamphetamine crisis, now we've got an opioid crisis. I think it will be harder to address. It'll be longer than those other issues because of the nature of this addiction. Once people are really caught up in it, it's got a high relapse rate. It's got high craving for long periods, so it's hard for people to get into recovery. But I'm absolutely optimistic that it's being addressed and that it's getting the attention it deserves.
Well, thank you for your clinical and medical optimism, for your innovation in that way. Before we wrap it up, I've just got to ask you one more question, because you have been walking this walk for 40 some odd years now. And we hear from a lot of young people who say they can't imagine the rest of their lives without a drink or a drug. They've run into a problem, they've been diagnosed as being dependent, they need to go to treatment. But a lot of times young people say, I can't fathom not having a drink or being able to use substances casually. Based on your own experience, having done this as a young person and now all these decades later, what's your counsel to those people?
I had the same impression. This just makes no sense. I would never be able to. I've never used anything legally. All my drinking was before I was of age, and I used illicit drugs. So even alcohol, I didn't get to have whatever kind of experience people have at 21 when they first drink and do so legally, whatever. And I went to college abstinent from alcohol and drugs. How many people do that? and I still have friends from my freshman year at St. Olaf College that I get together with, and they helped me out in spite of having no clue about addiction. I told them my story about my use and dropping out of high school, and they just pragmatically said, well, you shouldn't do that. and they stopped me from going to the punch bowl at the Christmas party in our dorm, things like that. And what I found is a lot of people actually don't drink or use drugs, and I don't explain it to everybody. I just, will refuse a drink at a party. And now that marijuana is legal, I haven't been faced with that question yet in a party situation, but it's probably bound to happen at some point. And yet it hasn't diminished my life experience. In fact, my life experience is so enhanced by being in recovery that I can't even imagine, the same sort of thought pattern I had as a kid that somehow my life won't be whole without using drugs or alcohol. And it's so remarkably different and so much better.
Well, thanks for your innovation, your expertise, and your passion, both professionally and personally, for all you've done to impact the lives of thousands of people, including me. Thanks, Marv.
Thanks, William.
And thanks to all of our viewers and our listeners who've tuned in today for the Hazelden Betty Ford Let's Talk podcast. Make sure you join us again for more engaging conversation with experts and colleagues in the field of addiction prevention, research, treatment, and recovery. I'm William Moyers. Thank you.